Hello, Dr. Brink, Dr. Cordero, and classmates. My name is Jenilyn Gray, and this is my presentation for Advanced Pharmacology. Before the presentation, I would like to start with a case scenario. A 65-year-old male comes into the emergency room complaining of lightheadedness, pounding heartbeat, and shortness of breath for about 5 days. When asked about his medical history, the patient states, I think I have high blood pressure because when I check my blood pressure at home, it reads high, around 160 over 90. But I don't go to the doctor because I don't feel any different until now. The patient's vital signs read blood pressure 138 over 95, pulse rate is 141 beats per minute, temperature is 97.8, respirations 22 breaths per minute, oxygen saturations 98%. The patient's height is 6'3" and his weight is 90 kilograms. EKG reveals a fast and irregular heartbeat. Do we know what the patient has? Yes. The patient has atrial fibrillation with a rapid ventricular rate. Atrial fibrillation, or AFib, is a disease that causes the heart to beat irregularly, sometimes faster than the normal rate. Typically, the electrical signals that make the heart pump start in the sinoatrial node, a special area of the heart's upper right chamber called the right atrium. The signal makes both the right atrium and the left atrium contract. That action pumps blood to the lower heart chambers or ventricles. The electrical signal then travels further down the heart, signaling the ventricles to contract, thus pushing the blood out of the heart to the rest of the body. In atrial fibrillation, unusual electrical signals in the upper chambers interrupt this typical process. The unusual movements cause the heart's upper chambers to contract irregularly, which makes your heart's upper and lower chambers unable to work together to pump blood effectively. So, what causes atrial fibrillation? If there is damage to the heart, causing damage to the electrical system, it's usually due to high blood pressure, like our patient does, and coronary artery disease. If there are changes in the heart tissue caused by aging, inflammation due to infection or genetics, conditions that may trigger a change in the heart signaling, like thyroid diseases, and other conditions like diabetes and sleep apnea, and lastly, lifestyle factors like obesity, smoking, and alcohol causes AFib. From a procedure perspective, treatment for atrial fibrillation includes electric cardioversion, where the heart is shocked to restore the normal heart rhythm. Cardioverting a patient depends on if the symptoms started less than 48 hours, thromboembolism risk, and other factors. Other procedures include catheter ablation and placement of a pacemaker. In this presentation, we will focus on the medical management of atrial fibrillation. Medications include beta blockers, non-dihydropyridine calcium channel blockers, blood thinners, and antiarrhythmic drugs. Based on the guideline, Pharmacologic Management of Newly Detected Atrial Fibrillation, developed by the American Academy of Family Physicians, rate control is preferred over rhythm control for most patients. Slowing the ventricular rate helps improve diastolic ventricular filling, thus reducing myocardial oxygen demand and improving coronary perfusion and mechanical function. Using our patient from the case scenario, he has new onset atrial fibrillation with a rapid rate for 5 days and is symptomatic. In the emergency room, physicians typically choose the drug diltiazem to control the patient's heart rate. Diltiazem is a non-dihydropyridine calcium channel blocker. The pharmacokinetics of diltiazem includes absorption in the GI tract, and undergoes extensive first pass metabolism, resulting in bioavailability of 40%. It is bound to plasma proteins and then distributed and then metabolized by the cytochrome P450 system, and is also an inhibitor of CYP3A4, which is an enzyme in the body that oxidizes drugs and toxins to be removed. This can lead to drug interactions. Diltiazem is extensively metabolized by the liver and excreted by the kidney and bile. Diltiazem blocks the calcium channels in vascular smooth muscle and cardiac muscle, preventing it from entering the cells and resulting in vasodilation and heart muscle relaxation. For us to understand the pharmacodynamics of diltiazem, let us understand what calcium does to the body. Normally, calcium goes through the calcium channels in the veins and smooth muscle, which is the heart, causing constriction and contraction. Diltiazem, as a calcium channel blocker, blocks the channels, preventing the calcium from going into the cell, resulting in decreased smooth muscle contractions and vasodilation. In AFib, diltiazem acts as a negative inotrope, leading to decreased force to squeeze the heart, and a negative chronotrope, leading to a reduced heart rate. Diltiazem IV is preferred for rapid ventricular rate due to its efficacy, shorter average onset time, lower ventricular rate, less impact on blood pressure, and with no increase in adverse events. Relating this to our patient in the emergency room, his diltiazem order will look like an initial IV dose, a bolus dose of 0.25 milligrams per kg, adjusted body weight, IV over 2 minutes. If needed, repeat the dose at 0.35 milligrams per kilogram, IV after 15 minutes. Maintenance dose includes IV continuous infusion of 10 milligrams per hour. Increased dose at 5 milligrams per hour to max of 15 milligrams per hour. Maximum infusion time is 24 hours. Sometimes patients are prescribed a PO dose, and it's usually around 120 to 360 milligrams PO daily. But in this case, the patient is still in the emergency department. So, what are the things that we need to know as nurses and we need to remember prior to administering diltiazem? Diltiazem may cause severe hypotension and bradycardia. If given through the IV, continuous monitoring of blood pressure and EKG is required. A comprehensive metabolic panel is also performed at baseline to track potential changes in electrolytes in kidneys and liver functions. We have to know the signs of diltiazem toxicity, such as profound bradycardia, dizziness, and organ dysfunction, hypotension, AV block, and at worst, cardiac failure and cardiac arrest. It is important to educate patients on the side effects or adverse effects of the medication, to call the nurse or doctor if they develop headache, rash, nausea, peripheral edema, and constipation. Caution the patient to change slowly when positioning to minimize orthostatic hypotension. Caution to wear protective clothing as it may cause photosensitivity. It may also cause dizziness and drowsiness, so avoid driving or activities requiring alertness. Okay, let's say that the patient from the case scenario's heart rate is now controlled and getting prepared for discharge. The patient cannot go home on IV diltiazem. What medication can be used to maintain and prevent the recurrence of AFib RVR? Another drug used for AFib is beta blockers. Again, we are still considering rate over rhythm. Propranolol is a non-selective beta 1 and beta 2 receptor blocker. Absorption is in the GI tract and undergoes extensive first-pass metabolism, resulting in bioavailability of approximately 25%. Propranolol is highly protein-bound and crosses the blood-brain barrier. It can also cross the placenta and distributed into breast milk. It is metabolized primarily in the liver and excreted primarily in the urine. So how does propranolol work? In our cardiac muscles, we have beta receptors where the neurotransmitters and hormones adrenaline and noradrenaline attach to resulting in increased heart rate, blood pressure, and vasoconstriction. Propranolol blocks the receptor, thus causing slow heart rate, low blood pressure, and vasodilation. Propranolol, like diltiazem, is a negative inotrope leading to decreased force or squeeze of the heart and relax fully, and a negative chronotrope leading to reduced heart rate. It also helps prevent stress-induced tachyarrhythmias. Propranolol is given as an immediate release tablet with doses beginning with 10 to 30 milligrams orally 3 to 4 times a day. Dosage may be increased up to 160 to 320 milligrams per day in 3 to 4 divided doses. Nurses need to know that routine monitoring of vital signs, especially heart rate and blood pressure, is important. Prescribing physicians must start at low doses, then increase as tolerated. The drug must be given with meals and at bedtime. And watch signs for bronchoconstriction caused by blocking the beta receptors. Patients must be educated about side effects and adverse effects of the drug, like smooth muscle spasms and impotence. Caution patient to change position slowly to minimize orthostatic hypotension. It may cause drowsiness, so avoid driving or activities requiring alertness. Patients may feel more tired than usual, and notify physician for severe bradycardia or hypotension. Another medication that is prescribed to patients with atrial fibrillation is anticoagulants. According to the 2019 AHA guidelines for selecting anticoagulants for patients, patients with atrial fibrillation and an elevated CHAD score of 2 or greater in men, oral anticoagulants are recommended. The options include warfarin, rivaroxaban, edoxaban, and apixaban. The patient in our case scenario is 1, 65 years of age, 2, has hypertension. He has a CHAD score of 2. Hence, he will also be prescribed with anticoagulants. The patient does not have any contraindications at this time, so he is prescribed with apixaban or Eliquis. According to Anderson from thrombosis.org, direct oral anticoagulants cause half as much life-threatening bleeding than warfarin. They're also more convenient than warfarin because they don't require frequent blood monitoring and can be given safely in fixed doses. Apixaban is absorbed in the distal small intestine, resulting in 50% bioavailability. It is bound to plasma and distributed, metabolized principally by the enzymes CYP3A4 or 5, and eliminated through hepatic metabolism, intestinal, and renal routes. Now let's understand how apixaban works. Normally, if we experience damage or trauma, our body activated activates the clotting cascade, which involves conversion of clotting factors resulting in thrombin formation and then fibrin forming clots. Apixaban is a factor XA inhibitor, thereby interrupting the clotting cascade and stopping the clotting process. So, how does AFib and apixaban work together? If the heart is not pumping properly, the blood is not fully pumped out of the heart. Stagnant heart equals clot formation, and that is why anticoagulants are prescribed for atrial fibrillation. Typical dosage for apixaban is 2.5 milligrams once daily. Stroke prevention in AFib is usually 5 milligrams orally twice a day. Patients should be monitored for hypersensitivity to medication. Patients receiving neuroaxial anesthesia or spinal puncture should be monitored for neurologic impairment such as back pain, numbness, and tingling, and weakness in limbs. And of course, we must watch for signs of bleeding from the GI tract, intracranial, and intraocular. Patient teaching must include side effects such as GI bleeding and intraocular bleeding. We must tell the patients to not stop taking apixaban without talking to the doctor. We must educate them to tell the doctor what herbal products they are taking, especially St. John's wort. We must also tell them to notify the doctor if they have or have ever had any type of bleeding problem, and to call their doctor right away if they fall or injure themselves, especially on the head. So, in conclusion, atrial fibrillation is a heart disease with irregular heart rhythm and rate, causing the heart not to pump properly. Given this, complications to AFib is clot formation, pulmonary embolism, and stroke. It is essential that we treat AFib as soon as it is identified to prevent these complications. Treatment of AFib is based on the AHA guidelines and varies per person, depending on their comorbidities. It is essential that when medications are prescribed, nurses and doctors must do their part in educating patients to keep them aware of the purpose, adverse effects, and when to call the physician. For my spiritual integration, or do you not know that your body is a temple of the Holy Spirit within you, whom you have from God? You are not your own, for you were bought with a price. So glorify God in your body. Corinthians 6:19-20. I understand this as God not only wants us to be healthy spiritually, but also physically. We must take care of our bodies because it is God's word. Our bodies are important because the Lord knows that we are happier if we have healthy bodies. We must be diligent and mindful of what we put in our bodies to prevent sickness. And, if inevitable, we must be compliant of the treatment and preventative measures presented to us. Thank you, everyone, for watching and listening to my presentation. Here are my references. I did not reference some of the images used as they are drawn by me. Thank you.